Hey, if you're an EMT or a paramedic on your wedding night or on an ambulance call and you don't bring your equipment to the bedside, you are caught with your pants down and not in the fun GNA way. Hello, everyone. Hope you brought your pants with you. He's Paul Gerard. I am Kevin Kelly. We are Gerard and Associates, your national EMS CQI consulting firm. Check us out at the website, www.gerardassociates.com. Yeah, baby, you're listening to the GNA Way EMS CQI podcast. Check us out on Podbean, YouTube, Apple Podcasts, all the others. We're grateful that you have tuned in. Hey, Paul, how many times have we seen on police body cam, family iPhone video, even Ring camera footage of medics standing around without a first in bag, the ubiquitous Life Pack 5, or even a drug kit? Kind of embarrassing, isn't it?
Yep.
Yeah? Is that it?
You want more? You want me to give you more?
Well, do you have more?
Probably not. Yeah, all the time. It's very, I'll have to say that it is less common today than it was 10 years ago. But it is still fairly common where people will show up to a call, go in to see the patient, and they have this philosophy that, well, let's go see what we're going to need for equipment, and then we'll hustle back out to the truck and get what we need, and then bring it back in and start patient care. And today's standard, that's just a no-no. You know, it's pretty much every protocol we have has some version of bring all your crap to the side of the patient so you can start care promptly. Some sort of verbiage similar to that, and people still sometimes don't do it.
I don't know about you. We've worked together. We started as paramedic. Well, I mean, I was an intern, but then we became paramedic partners. I want to say back in 1990. So we worked, I want to say every Friday night together, 7 to 7. And then I think we had a Sunday, or at least at one point we had a Sunday. But my point is, not one call can I remember working with you or any other partner for that matter, where I could put myself in the paramedic's shoes who doesn't bring the equipment to the patient's bedside.
Yeah. We just didn't do it. It wasn't natural. You know, we worked in an intercept service, right? A hospital-based intercept service. So We show up, we just grab our stuff and we go into the call. Unless, you know, the EMT's saying, hey, we don't need you for care, but, you know, we could use a hand carrying them out. Can you come give us a hand? Something like that. But in terms of, you know, everyday patient-to-patient interactions, we always brought our monitor, our first in bag, and our drug box on pretty much every call. So for us, it's old habit, but it's not habit for a lot of folks today. So, you know, it's important. It's a critical thing to do to keep yourself out of trouble.
How does it happen? I mean, how do we? I think we almost talk about this every podcast, but you know, how do we get to the point of it's almost apathy, where you presumably have high quality priority EMS dispatch, you know, medical priority dispatch or some dispatch algorithm. The information that the dispatchers are generally getting from the callers is better now than it was 20 years ago.
That's true.
So we're armed with this information.
Mm-hmm.
But that whole make ready, be prepared, you know, all of that.
That's the Boy Scouts.
The Boy Scouts, but it's not the EMS Scouts, and that's kind of the point. Is like, what happened, man? I mean, we get into these calls. I mean, we get in these calls. We got information that it's altered mental status.
Yeah,
and we got to climb 3 flights of stairs and validate that the patient, in fact, is altered mental status before we go back down to the truck to get the first in bag.
Right.
And the glucometer and, you know, all of the necessary tools for us to assess the patient.
Yeah.
You know, what's going on with that? And how prevalent is it actually?
I think for agencies that we've been working with for a while, it doesn't happen very often anymore. You know, here and there it'll happen. Yeah. And it's usually because we've kind of worked it out of them, you know, over time. Mm-hmm. And when they don't go in with their equipment now, it's usually because there was some indication that perhaps they weren't going to be, you know, the cop said, everything's fine here. Patient doesn't want to go to the hospital over the air. So they show up and they think, well, bring your clipboard. It's probably going to be a refusal, or your tough book or whatever. And then they get caught with their pants down, where it turns into a call and somebody's going to go out to get some equipment or something like that. But in agencies where we're starting for the first time, where we're just getting to know them and whatnot, it happens a fair amount of the time. And people have just gotten, I guess, lazy to the point where they feel comfortable just going in to see what's going on. And they don't think anything of, well, what if I get in there and something bad happens, right? And this is EMS, man. This happens all the time, where dispatch tells you the caller, called in, they're complaining of whatever, they're staying on the phone, that they just want you to check them out and that they don't want to go to the hospital. So it's a wellness check or something like that. And then you get suckered into that and you go in and say, well, this isn't a big deal. And you go in and you get caught with your pants down when it turns out that the patient's unconscious or something by the time you get there. So, and it happens all the time in EMS, right? This is not you're not working at McDonald's and somebody coded in front of you at the counter and it happens once every 25 years. This is our job. So you really should be prepared. You should be ready to go. Pretty much every protocol now says it in writing, and they had to put it in writing because people would not do it. And it says, bring your patient equipment to the patient side. Now, that's the general rule. The problem, where this gets interesting in my mind, is in the weeds. And you've called us the dirt dogs, right? We're always in the weeds looking at the lowest common denominator of each EMS quality improvement and patient care. And I love that term. And this is one area where when we're in the weeds, you find that it's not always as black and white as it sounds. So oftentimes, bring all your equipment to the side of the patient. I'll ask you, Kevin, you're a former paramedic, and what is all that? What constitutes all your equipment to the side of the patient? What should they be bringing in?
I'll do the lawyer. Well, who's paying me first? Am I on the plaintiff side or the defense side? Because where you stand depends upon where you sit. And
you're on the side of the angels. You're on the side of good patient care.
All right, so I'm the plaintiff's lawyer, right? I mean,
right.
Okay, yeah. I mean, so
yes, right.
So yeah. So I'm going through this thing. And I'm not a plaintiff's lawyer in real life. I'm a criminal defense lawyer. I don't sue EMTs or paramedics, but from time to time we are called on to consult.
Yep.
And we do that. But I want to, from the time the call came in, with that 911 audio, and all of those excited utterances about how Aunt Sally clutched her chest and hit the floor, to the time that the patients cleared up from the call and got in service to the next one, I want soup to nuts everything. And specifically, I want to focus in on that 911 call, how it was dispatched, the information that the EMTs and the paramedics got from the dispatcher,
right?
Which may or may not have been correct information. The caller on Aunt Sally may not have gotten the information right. It may have tunnel visioned dispatch and tunnel visioned the EMTs and paramedics en route to the call, right?
Well, let me give you an example.
You're going to let me answer the question first?
I thought you did already. You said bring everything. Oh, all right.
Well, no, not bring everything, because I know where you're going with that. What do you want them to bring? The jack? You want them to bring the backboard? You want them to bring the stair chair? What do you want them to? All of that stuff. No,
that's where I was going to go. Yep.
Yeah. So I expect that the paramedics are going to use, here it is, reasonably prudent clinical judgment based on their jurisdiction, based on the reasonable information that they have at the time they pulled up, in making the decision as to, generally speaking, what protocol they would be operating under, and therefore, in accordance with that protocol or protocols, what equipment would be needed to remedy the issue of time versus time is brain and time is muscle. That's the more completed answer to my question, Paul. There you go.
So you still didn't answer, what equipment would you actually bring? So let's say you got an unconscious guy comes in as an unconscious patient. So you're arriving on scene, patient may be unconscious. What specific pieces of equipment would you bring in with you?
At a minimum, first in bag, oxygen, all of the equipment that goes along with the first in bag, your suction, your O2, your cardiac monitor. I mean, your drug kit. And if you're on the third floor, you might want to think about extrication and moving the patient. So at least a stair chair. Now, I would think that those pieces of equipment would sound, bringing those pieces of equipment would sound reasonable to an OEMS investigator, would sound reasonable to an administrative law judge, would sound reasonable to a judge in a trial for negligence.
Yeah. Well, see, therein lies part of the problem, because what providers will do on pushback when you make that recommendation, say, listen, there's only two of us. I've only got two hands. You're asking me to bring in 100 pounds worth of equipment. I got to hustle it up 3 flights of stairs. I'm not going to need half of it. I think it's unreasonable for us to bring, and then they'll pick a piece of equipment they think is unnecessary in that case. So, and that's where it gets a little bit dicey. But in general, I think you're right. I think we all have a first in set of equipment, right? Usually your cardiac monitor, your first in bag, or your primary kit, whatever you call it, your drug box, your O2. At a bare minimum, right? And then, like you're saying, there are some services that require that you bring your extrication device, whether it's a stair chair or the stretcher. And we see that in urban systems where you're working in high rises a lot. So you're not going to go up to the 20th floor and then say, okay, Bob, go down and grab the stretcher. You'd bring that shit in with you. You bring it in, for every call, just in case. So that's not unreasonable. If it's a traumatic call, you swap out your first in bag for a trauma bag, perhaps, or if it's a PD patient, the PD patient. But you're absolutely right. The issue is going to be when it gets looked at later on, it always goes back to how was the call dispatched? What information did you have going to the call? Now, going to the call, you had inadequate information. That's not your fault. So, and we had, there's a case I was going to bring up a minute before you rudely cut me off. There was a case a few years back where a little old lady called, said her baby's not breathing. So they showed up, took all their pediatric equipment into the side of the patient, got there, and was a 50-year-old guy in his underwear laying in the bed, overdosed. And, to 80-year-old mom, that's her baby. To the rest of us, the rest of us, that's an elderly pervert guy. Right. So they, had to hustle back out, get all their equipment for, an adult narcotic overdose who looked like he might be arresting, quickly. But that's how, that is not on the providers. So you bring in the equipment that it seems reasonable to bring in based on the information you have at the time that you arrive at the call. And so here's another cautionary note, though, that I want to bring up, is that we say stuff like bring in the O2 bag, and we're presuming that all the right equipment is in the O2 bag or the primary kit or even the drug box. But we interact with a lot of agencies where they do weird stuff. And we had one agency once that didn't keep their CPAP in the O2 bag. They kept it in the ambulance. So their O2 bag had O2 equipment. They go in, throw them on an non-rebreather, throw them in a stair chair, and take them out to the truck. And so the auditor says, hey, how come you didn't have them on CPAP? And they say, well, that was out in the truck. But I had them on O2. Well, O2 is not sufficient, right? You're there to start treatments that's going to reverse the condition for which you're there to treat. In this case, if it's bronchospasm or whatever it is that requires maybe a neb and CPAP or just CPAP or whatever, O2 helps with the symptoms, but it doesn't reverse the cause that you're there to treat or start to reverse that cause or minimize that cause. So in most cases, the regulatory bodies are looking for you to start treating the patient to the degree that it's going to be effective in reversing their condition, their acute condition. And simple O2 is not the case. So, and interestingly, when I went back to the providers on that and said, hey, how come you didn't have CPAP? How come you didn't put on CPAP? And they said, well, it was out in the truck, and send somebody out. It was quicker to just throw them on the stair chair and extricate them out and put them on CPAP once we got out in the truck. Now, that's a second problem, right? Is making that decision instead of sending somebody out to the equipment, deciding to bring the patient to the truck and to the equipment is usually not the best answer either. But in this case, when I said, well, why didn't you have CPAP in your O2 bag? And they say, well, management doesn't want us to keep it there. Why not? I don't know. We're not allowed to change the equipment in the bag. We don't have CPAP in the bag. When I went and asked management, nobody had an answer for why they didn't have CPAP in the bag. Somebody said, well, there's not enough room in that O2 bag to get all this shit in, so we have to leave some stuff out. But when you go in and you inventory that bag, they've got 14 non-rebreathers and no CPAP. Okay, let's take out 1 or 2 non-rebreathers and replace it with a CPAP device. So we see that often. We've seen that with narcotics too, Kevin, where people don't keep narcotics in their drug box. They keep it stored in a locked cabinet in the ambulance. So they go in, and if they're on scene, they need narcotics. Either somebody has to hustle out to the truck to get them, and that's a delay, and this is the one that really kind of gets me going as a QA guy, is that a lot of providers will opt to say, instead of sending somebody out to go get that piece of equipment, let's just throw the patient on the stair chair or on the stretcher and get them out to the truck. And that's an even greater delay. So you're stuck behind the 8 ball if you're at that point in the decision-making process that you've got to make the decision whether to send somebody out to the truck or take the patient out directly. And that shouldn't happen in most cases. It may happen in some cases where something unexpected happens and you need something that you don't use very often. But in most cases, the first-in stuff should be taken with you.
Yeah, and that includes the narcotics, Paul. Even if the narcotics, because we see this, one of the CAS accreditation standards is you got to lock the narcotics.
Double lock, usually, right?
Double lock, right?
Yeah.
And one of the issues is, hey, you get that vague call for a 50-year-old female, and she's complaining of fatigue.
Yeah.
Right.
Yeah.
And you get up there, and your tunnel vision based on the dispatch, what you got in your head, how you're preparing.
Yep.
For that initial response and getting to the patient's bedside, you're up there thinking one protocol, and you should be in the ACS protocol, and you don't have narcotics,
right?
And that's a problem. So you got to have a policy in place to address that, and you have to have ongoing. You don't have to have anything. This is America, but in my opinion, you have to have ongoing monitoring to make sure that your troops are bringing these narcotics that are separated from the drug kit because they're double locked,
right,
to the patient's bedside.
Yeah, and the way we find it, interestingly, a lot of agencies don't really monitor for that, right? They once the crews go out on the call, unless they have a supervisor who responds with them or something like that. But in most cases, there's not really a way to catch it. And what agencies say to me is, well, we don't know if they're bringing it or not. How do we know? And I say, well, in your QI process, when you're looking at the run report, you should be looking at time to interventions. And if it took you 12 minutes to get the CPAP on or to put them on O2, the question is not just why didn't you put them on O2, but did you even have the O2 with you? So you can sometimes get to those answers if your QA process is asking the right questions. And once it gets on the QA guy's radar screen to be looking for this, all of a sudden these calls start jumping out at you where you're like, hey, how come it took you so long to narcotics? It took you 15 minutes. Why didn't you give it to him? Why'd you wait to get out to the truck instead of giving it to him on scene? Well, I didn't have it with me on scene because it's locked in the truck. And instead of sending something, and then it starts snowballing with all that stuff we just talked about. And as the QA guy and as management, you really have to look at whether you've got the right equipment going in and the right kits in the first place. Because if you have this double lock mechanism that you utilize, and there's different ways to get to that. One is you can have a lot of agencies have small narc boxes that are locked and tagged, and then they lock it in a drug box, and that's your double locking mechanism. But for agencies that don't want to do that, because I think it's an awful lot of locks to get through on a scene to get to the narcotics, they leave it in the truck where it's still double locked, but it's in the truck now. And in one agency, what they were doing is the paramedics, because they didn't want to get gigged by QA for not giving narcs in a timely manner, is they would take the lockbox out of the ambulance, the smaller, transport version, and they'd put it in their pocket and carry narcs with them on calls all over the place.
Yeah.
So now they've got narcs in their pockets.
Right.
So
big risk.
Yeah, big risk. Yep. So, this stuff sometimes doesn't make sense, but people sometimes do things that make sense to them, but it's not necessarily the right way to go. And management and QA needs to know that and intervene.
And they got to operate in the constraints of a budget as well. But, some of these agencies that separate and double lock and have a different locking mechanism for the narcotics, it is all monitored. The time that knockbox got opened,
right?
The whole shebang.
Yeah.
And if it's open for a prolonged period of time, the supervisor gets dinged on their cell phone. So there's a lot of oversight and a lot of data being collected on knockboxes and all of that. But again, if you're not looking at that data, then the data doesn't matter.
Right.
So you got to look at that. All right. One of the delayed treatment and compromised stabilization are always at the top of the list when I think of duty, breach, causation, and damages. Paramedic negligence, and this is why you gotta bring at least some basic equipment. Whether it's XABC, airway breathing, exsanguination, stabilization, ABC, or just ABC, you got to have something at that patient's bedside
Right.
to decrease that time is brain
Yep.
and time is muscle. How is there an ability? How do you coach that up? I guess that's the question is you're sitting in front and we can't put ourselves, I don't get this quite frankly. And we've seen some videotape, the Illinois situation with the two paramedics, who had this case that they brought nothing to the patient's bedside except a bad attitude. You saw the issue in Colorado with the ketamine catastrophe. Originally they got to the patient, they didn't have any equipment, and this is on video.
Yeah.
Looks pretty apathetic.
Yeah. Was there a question in there?
The question is, how do you coach that up? How do you coach that out of your organization?
Right. Well, again, you got to make a big deal of it. So you got to inculcate that in everybody from the day they're oriented, their first day on the job. And you need to make sure that everybody knows systemically that your organization, that's how it's done. So that's the first step, right? Make it a big deal. It should be in policy. If you don't have something in writing, you should have verification mechanisms, whether they're site supervisors who respond to calls randomly to check things out, or whatnot. And your QA folks on the other end can audit calls looking for delays in care and treatment. And then when you talk to providers, you need to ascertain what was the cause of that delay. And if it was because we had to go out to the truck to get something, ding, 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 that can't be tolerated. So you've got to get to the point that it's just habit for people to take in certain equipment on every single call, regardless of what type of call it is. And if you don't enforce it to that level, if it's not a big deal to you as a manager, it's not going to be a big deal to the individuals out in the streets. So make it a big deal, be consistent with it. And, if people are doing it and they refuse to comply, then you got to kind of get tough with them. They need to do it. It's their job. It's critical to get patients the care they need in a timely fashion. That's why states have been putting it in protocols and regions and medical directors have been putting it in protocol because of its level of importance. So yeah, it's got to be coached up or coached out, as we sometimes, talk, you and
I. You mentioned times as a I'll call it a forensic piece of evidence of EMS CQI. Times to the bedside, times that patient care actually started. We talked about the knock box time issue and determining whether or not they brought it to the patient's bedside.
Yep.
Based on 20 years, 400,000 plus EMS CQI audits and CQI one-on-ones, what other tips can you give EMS CQI pros? What are the things in the or pieces of data within that patient care run report can you tease out to drill down on this important topic?
Yeah, one is to be suspicious of every report you read. And the key way to try to determine that is generally with the times to skills and whatnot, as we mentioned. But you can also get it sometimes in the narrative when people will say, we arrived on scene, we started procedures, we did A, B, C, and D for procedures. And you say, well, okay, well, how come you didn't suction them sooner? That doesn't make sense that you suctioned them so far later in the call when the patient, appeared to be vomiting on scene and you didn't suction them until you get out to the truck. So they sometimes in the narrative will kind of say it, say once out in the truck, we then started to suction the patient, type of thing. So you got to kind of tease that out of the narrative and have a healthy index of suspicion, even on the calls where nothing bad really happened. And I think this is one of the weaknesses of EMS CQI programs is that CQI is looking for the worst of the worst calls to then bring people in. And it's a product oftentimes of funding. They don't have enough, resources to do the job thoroughly. So they just look at critical calls like cardiac arrests and chest pains and they review those. But you can see this type of activity most blatantly in the calls where there's nothing really exciting going on. And it's because it came in as something boring, little old lady with a flu, or her lab values are off, wants transport to the hospital. Those are the ones that providers often will cheat on. They don't usually cheat on the cardiac arrest. They're usually smart enough to bring in some sort of equipment, maybe not the right equipment, but they bring in something. So be curious and look at those lesser important calls and see what it's telling you in the narrative and in the times to skills and procedures and treatments. And often those will be the tip-offs.
To help CQI officers and get through this issue, would you recommend that DMTs and paramedics actually document somewhere on the run report? That what specific equipment they actually brought. We brought the first in bag. We bought,
Absolutely. It's actually best practice in terms of documentation. And a lot of our agencies, when we work with providers, they do that. We teach them to do that. Is the first things we arrived on scene, brought in our PPE, which, we wore PPE into the house.
Right.
We brought in our monitor, our O2, and our first in bag. If that's all they brought in, okay, but they documented it. And then we arrived on scene, and here's what we were confronted with. So they've gotten used to the habit of putting that right up front in the very beginning of the report. When we arrived, this is the equipment we grabbed when we headed into the house. So, that's best practice, Kevin, in terms of documenting. And that's another way that you can kind of tell if you start, really reinforcing with your providers that they need to document that it's important in their overall documentation. And if providers don't put that in the documentation, you give that feedback to them that they're not doing it and that they need to do it, then you're going to see better compliance, other than the folks who outright lie and just say they brought everything in when they didn't, which is always a challenge from a CQI process standpoint.
Talked about governance. It's got to be a high priority issue. It's got to be key. Shortening that time between getting there and getting resuscitation to the appropriate patient.
Right.
Got to have a policy.
Yep.
Right. You agree with that?
Yeah. And you might want to even embellish the state's protocol, even if the state has a protocol. Yeah. It usually doesn't give you all of those scenarios that we talked about. It usually simply says bring appropriate equipment to the patient's side. So you might want to have an added policy that specifies what types of equipment under what circumstances, as examples for perhaps. So it is good to have your own in-house policy that maybe expands upon what protocol might say.
Good practice to have an EMS CQI committee. The EMS CQI committee oversees the policy, among other policies, on ensuring that the appropriate equipment gets to the patient's bedside. You'd agree that there ought to be some education on this policy, would you?
Yeah. Oh, absolutely. It should be part of your orientation. It should be part of your refreshers. It should be part of your M&M rounds. Your medical director should be on board with this, right? Yep. So if you say to your medical director, this is what we're holding people up to, are you in agreement? And 99.9999% of medical directors will be. They'll say, yeah, absolutely. This is important. So then you can help us during M&M rounds. I want you to reinforce it. If you're reviewing our calls that we've sent to you for medical director review and we haven't opined on that issue, we'd appreciate it if you would, right? If it comes from the medical director, it means more. So lots of education and reinforcement from every angle shows that everybody's on the same page with this, and that if you don't bring it in, you're going to be the outlier. People are going to rat you out if you don't bring your equipment to the patient's side, because everybody's doing it.
And you would agree, as a EMS CQI expert, would you, that the medical director ought to be part of the spearheading of this initiative, ought to be part of the policy evaluation process, ought to have the medical director's hands in the education process, ought to have medical director hands as part of the EMS CQI oversight process as well. You'd agree with that?
Oh, yeah, no doubt. They should at least be aware, of what you're putting out in terms of, this sort of detail and whatnot, because they'll have opinions. You may create a policy that says, hey, we want A, B, and C on every call. And the medical director might say, hey, I want D on every call. I think you should have your, fill in the blank, right? You should bring in suction to every call just in case,
Right.
And then you can debate that, right? Because the time to debate this is not after a call where somebody's accusing the field provider of fucking up, right? That's not the time to discuss the merits of whether they should have brought in suction or not.
Right.
The merits of whether on which patient types, what call types should suction or whatever be brought in on should happen before there's a problem, so that you can then enshrine it in protocol, policy, or whatnot, and then educate the shit out of it so that people know it well in advance. So you can head the problem off at the pass as opposed to waiting for it to occur and then having a medical director say, I can't believe you guys don't bring suction to cardiac arrest type calls. Why don't you do that? That's right. Important. You can't have a patient who's, aspirating while you have somebody running out to grab suction. So anytime a call comes in for an unconscious or a cardiac arrest or something that could be arrest worthy, you should have suction, for example. So he or she may have some opinions on some of these call types that may differ from what management might have. So soliciting that input's a good idea.
Medical directors got to be involved in the routine internal monitoring and auditing of this issue and needs detailed reports.
Right.
You'd agree with that as well, right?
Yeah, no doubt. And this stuff should be reported. So, if you document this and you see it as a problem, it's something that you should track.
Yeah. And for the organizations that do this in-house, would be a good idea, and I would recommend this. Just to cover your ass, cover your bases, is periodically, even if you're monitoring this, have somebody from the outside do an external objective audit, even if it's just on this one particular issue, which is you're not going to see this at NEMSQA. This is in the weeds, right? This is the dirt dog. Right. In the weeds, tier 1 operator, Navy SEAL, the Illuminati defines the big picture issue. We lays the target, and so that's what we do. But every step of the way, got to have medical director buy-in, have a periodic audit done from somebody from the outside that can possibly give you some tips on bolstering your AMS CQI program.
Yeah, bias is always a problem. Internal bias is always a challenge for any management level activity that's going on. So, and this is patient care. This is important stuff. So your CQI department might be doing a great job, but it's always nice to have somebody do a review and give you some feedback and say, okay, based on some data that we've reviewed, here's a couple of areas that might be weak, and that can give a fresh set of eyes and even some creative ideas on things that they should be monitoring that perhaps they're not monitoring and that sort of thing. So independent, unbiased review, even if it's sporadic, if you're doing everything in-house, it's not a bad idea to get a periodic once a year, get an outside eval to see how it compares to what you think you're doing.
Yeah, absolutely. We talked a little bit about discipline and enforcing doing the right thing.
Yeah,
coach them up or coach them out. We have a GNA. We have our leadership model we call the 4 C's.
Right.
That's what we employ to try to modify the behavior, increase those Moneyball scores.
Yeah.
But so I don't want to belabor that anymore. But the entire point, I think, culminates into what bad things can you prevent from happening to your patients, your paramedics, and your organization. And in order to get and drill down and forensically find out the details, you got to be in the weeds. And this is one of those topics that generally EMS CQI pros don't want to be in. They want the bigger ticket, sexier, clinical topic. Yeah, so this is one of those things which, kind of gets pushed by the wayside.
Right. Until there's a problem.
Until there's a problem. Yeah.
Somebody didn't bring their cardiac monitor because the cop said this is a DOA. You don't need any equipment. Since you're here. And so the providers lackadaisically just go over there and kind of eyeball the patient. Yeah. And this is actually a real case or a lawsuit that we reviewed for a legal case is the providers brought in their monitor because the cops were saying just that, patient's dead. We just need you to verify death for us. They said, okay, let's just bring our monitor in. They walked in, found that the patient was recently probably deceased and should be worked. And now all they've got with them is their monitor. So somebody had to run out and get all the other equipment and it caused delays in everything getting done because they listened to what the cop said when they arrived, and they're not necessarily trained, or even if they're trained at the EMT level, they might not be experienced in seeing patients and familiar with the most up-to-date protocols on how to verify death and those types of things. So you always have to be doubtful and go in there with your own set of eyes. And in order to do that, you have to bring in your equipment.
Whether on your wedding night or the patient's bedside, right? I mean,
Right.
Did you ever not bring your equipment on a wedding night?
I don't think so. On a wedding night, nope. I always had my equipment on me, so to speak.
Yeah.
So, yeah.
It would be pretty embarrassing if, after all of that and the big meal and the dancing and, precious and few other moments, all of that.
Yeah.
To not bring your equipment with you.
Yeah. You got to be able to perform when you need to perform.
Yeah, and a lot of anxiety, too, and you got to perform under that anxiety. So there's a lot going on, not only on the wedding night, but you get the same anxiety on a paramedic call as well.
Yeah. Again, we say this jokingly, tongue in cheek, but on a call, you need to have your equipment and make sure it's operating properly, right? So you did your vehicle checklist. You made sure your batteries are charged in the monitor. So just having it with you is not necessarily good enough. Did you check it out? Did you have everything you needed to get there and say, we don't have any 7.0 tubes. I didn't check the intubation kit this morning and the last shift, those assholes, and now I need one that's not there. Well, assuming it wasn't, an 8:00 call at the beginning of your 8:00 shift and you went right out, you should have found that yourself, right? So It's not just having the right equipment. You got to make sure that it's operational, that it's not expired equipment, such as drugs, and that everything is in working order. So
you can have all the batteries you want, but if they're not charged, you're not defibrillating.
Bingo, right? All right, my friend. So what else do you have to? What else do we want to talk about on this topic?
Well, I think I want to bring back the. You just mentioned it, the deceased person, and there's been a couple of cases in the news where we are apparently leaving live people at morgues. So I think that's an interesting decision-making, clinical judgment conundrum. But on this issue, no, I think we covered it all. I think we hit it on every show. But you're on ring cam video, you're on iPhone video, you're on body cam video.
Right.
That whole Illinois debacle,
right,
with Earl and this alleged excited delirium, and how horribly EMS apathetically didn't treat him.
Right.
That's all on body cam.
Yeah.
And understand one thing: I deal with body cam in my life almost every day, because as a criminal defense lawyer, you do, OUIs is body cam, is dash cam, all kinds of things.
Right.
Is booking video. And you're trying to take all of that evidence and put together a screenplay that hopefully leads to a dismissal, or if you won't get a dismissal, it'll lead to an acquittal in trial. But I'll tell you, I got a case now. I was like geared up. I'm like, my client's telling me the truth. My client's getting fucked. And then I look at the body cam video and I'm like, I got a problem. I got to rethink my theory of the case on this. So it's amazing how much we are in a fishbowl, and how when that bell rings, you dispatch to that call. Part of your mindset in thinking drives behavior has to be that I'm going to be on camera and I want to look good on camera.
I'm always being watched.
Yeah, you're always being watched. Right.
Yep.
And
even without camera, Kevin, there have been interviews from OEMS where they just asked the patient, what equipment did they come in with? Nothing, or bystanders, family members, people on the street. Right. And so you can't lie on the run report and expect that you're going to get away with it forever at some point. And then it's going to bite you even harder because now you've lied on your run report. So not only are you accused of not bringing in your equipment as you're supposed to, now you try to cover it up. So if you're going to get whacked once with the bad stick, the first time you're going to get whacked 3 or 4 times with the bad stick for trying to cover it up. So do the right thing.
Yeah, that's a whole other issue too, is that, and we've talked about it on one of the shows, is that the cover-up is worse than the crime.
Yeah.
And, you're in EMS. It is not a controlled profession. You're out there in the environment. There's all kinds of shit happening. You have to you have to process in milliseconds all kinds of stimuli, all kinds of information. The bottom line is you're going to fuck something up every now and then.
Mm-hmm.
We've done it.
Mm-hmm.
We've done it. We've all done it.
Yeah.
And it's going to happen to you. How you handle that going forward,
right,
is huge.
Right.
And
always do the right thing.
You don't want to be accused of lying and have that follow you. It's one thing to screw something up and have that follow you. You went through some remediation. You made a mistake, whatever.
Yeah.
The problem is if you're a liar, you can't trust the paperwork. You can't trust them on the stand.
That goes to character, and nobody wants to hire somebody with a lack of character.
That's correct.
Do the right thing. Bring your equipment to the patient's side. Use it as needed. If there is a screw up of some sort, fess up. Just be accurate and complete in your run report or incident report if it's something that doesn't go in the run report or whatever. And if you do the right thing, even if there's a problem, the repercussions are much smaller than if you're just trying to skirt the system and not do the right thing.
Well said. All right. I think that's it on my end. You good?
Okay. Yep, I'm good.
All right. Well, everyone, thanks for tuning in. Really grateful. We've gotten a lot of great feedback on the podcast, and we really appreciate you tuning in. We hope this information is valuable to you and that you can put this into play tomorrow or right now and automatically just out of the starting gate improve your patient care. So for Paul Gerard, thanks so much. Have a great day. We'll see you the next time.
Stay safe, everyone.
On 5.